modularity. So I'm going to talk to you a little bit about modularity. These are my disclosures. So the reality is we've set an incredibly high standard with hip arthroplasty. Patients are very active, they're very demanding, they have high expectations. Many of our patients live a perfectly normal life with their hip replacement. And in order to achieve that, we've got to get absolutely the right biomechanics for that case, and we've got to get the implants right for that patient. And that's where modularity comes in. You're all aware of the benefits, or if you like, potential benefits of modularity, because we can address version, length, offset, and restore the right configuration for that patient. So we have more intraoperative options, we can uncouple the head from the stem, we can hit the so-called sweet spot, and we get less impingement, good stability, less inventory, and you could just revise that bit if you needed to. And there is a track record. Let's not get confused here, because I'm going to tell you some bad things about modularity. None of you would wish to discard the modularity that happens between the head and the neck. We're all too wedded to that. And there are some implants which have this kind of modularity that you see here that we're all very used to and that have an excellent track record. And if you're faced with this kind of DDH type scenario where you have to do complex osteotomy, where you have to change the version, then some modular implants are priceless from that point of view in terms of helping you address that. And in revisions, I think it's something that's revolutionized what we do. It's really allowed us to overcome the problems of previous revision stems by reconstructing around distal fixation and really aiming the revision as high as the primary by using modularity. So let's break it down and consider the fact that there are various types of modularity, some of which are well established and good, and some of which are now causing problems that we need to be aware of. And this is a good paper in Bone and Joint Journal earlier this year summarizing that. But there are some risks to modularity, which is why we're really discussing it, and they're primarily to do with modular necks. They're expensive, their adoption was largely uncontrolled, and there have been a variety of modes of failure here, notably in terms of fracture for some implants, but also in terms of corrosion, dissociation, and some third body wear issue. So we have seen problems with modular neck hips to the extent that some of them have been the subject of alerts, and quite a few of them have now been withdrawn, with problems of corrosion and, to a certain extent, fractures. And that's something that we've all become aware of, and that as a society and as a profession we cannot afford to have hanging over us. So we've got to really understand what this problem is, how it works, and what we're going to do about it. And so in the UK we have these field notices where things like the ABG2 stem or the Rejuvenate are withdrawn because of the problems they've created. And if you look at the Australian Register, you can see that the type of femoral neck you have, if you have an exchangeable femoral neck, in other words, femoral neck modularity, you have a much higher failure rate for a variety of reasons, not just corrosion. The other interesting thing here to bear in mind when you're trying to unravel this problem is when you look at these failures, and this is again from the Australian Registry, you will see that there are certain types of modular stems that fail a lot, and there are others that fail very little. So there may well be design features that will lead us towards failure or success with a modular stem, and we really need to unpick that. So there's been a lot of work, and there's a recently published consensus from the Academy, the American Hip Society, and ARCUS breaking this down. So if you're now looking at modularity, you need to think about it in terms of patient factors, implant factors, radiographs, and also in terms of, the slides are advancing on their own, in terms of metal ion levels and in terms of cross-sectional imaging, which are the two modalities that metal on metal has taught us. And then you can recommend. So there are some low-risk modular groups when you have, for example, titanium on titanium with low metal ions and nothing bad on MRI. There are some moderate risk groups, particularly cobalt chrome on titanium or cobalt chrome on cobalt chrome, moderately elevated levels, and you can see some abnormalities on MRI scan where you need to monitor, if not revise. And then there is the high-risk group, which you see particularly with cobalt chrome on titanium, where you see the high cobalt chrome ratios in the blood. Remember how cobalt and chrome go up with metal on metal. If you have a high cobalt and a low chromium, then that's a significant indicator of corrosion, and those are a big problem where you need to consider revision. So this is all published now, and it is a concern in terms of what's happening. So should we stop using modularity? I think the reality is we need to understand it, and in order to understand modularity, you need to understand the taper. And we have a big literature on the taper going back to 30 years ago, understanding the geometry of the taper, the roughness, the angles, and really learning how to cope with that and optimize it. And we have largely managed to ignore that in some of the developments. The reality is that modular junctions rely on frictional interlock, and the micromotion that occurs has many factors that influence it. And in our quest over the last 2 decades for thinner femoral necks, bigger offsets and bigger heads, we've created an environment of fretting corrosion. And that's the problem that we're facing increasingly, and that Craig Della Valle and others have written extensively on. The reality for you now is that we have the data to know what is a good and what is a bad taper, and we just need to unravel that and get those factors into play and work out the risk-benefit equation. Because it may be different in a primary, where modularity is not so critical, than in a revision, where modularity may be more important to you. So just to summarize for you, is there a role for modularity in 2014? The reality is, of course, there is, because we still want modular heads. We're not going to go back to completely monoblock stems. So we have to be careful how we innovate, but we also need to beware overreaction. We definitely have introduced a new facet into our thinking, which is corrosion, and we need to bear that in mind. I would put it to you that ultimately, as we move forward, we need to bear in mind there may be still some indications in future for corrosion, but before we do that, we need to get the design right, simplify the technique, and make it something that everybody can do. And it certainly will be at most 5%, if not less of our cases, not 95%. And for me, it's going to be an area we use it in revisions, because in primaries, I don't think neck modularity really has a role to play at the moment. Thank you very much.